So good morning, everyone. The AT&T network says it's 11 a.m., so it must be. So our second panel differs from our first. In the first, we heard about a disease that didn't exist in the minds of medicine in 1975. In contrast, people have been giving birth for as long as anybody can remember. And we're lucky for it, because without it, we would be in big trouble. But there are many challenges to that actually haven't been met, and we have a panel on maternal and fetal health that's being moderated by Peggy Hostetter, who is the Sabin Professor at the University of Cincinnati and one of the many pediatricians to participate in today's panel. So, Peggy, I'll turn it over to you.
Jeff, thank you very much. Welcome. I know that my colleagues and I are honored and grateful to be with you today to talk a little bit about the issues of maternal mothers and children. Now, as a pediatrician, I began here in Boston in 1975, just this month as an intern at Boston Children's Hospital. And of course, it was my patients who made me a pediatrician. But before I came to medical school and here to Boston Children's, I was a graduate student in 19th century Victorian literature. And so to open this panel, I'm going to ask you to take a walk with me through a 19th century cemetery. It may be Mount Auburn in Cambridge. It might be the Grove Street Cemetery in New Haven. Might be Spring Grove in Cincinnati. And amidst all the funerary monuments that you would see in the Victorian times, take a look, and every now and then you'll be brought up short. Here's a tombstone of a young woman who died at 22, at 24, maybe even at 18. And then next to her will be that little lamb in stone, because that was her child. So do mothers and children still die from birth? Do children still not live through their first year of life? Unfortunately, that's a global fact. And the panel here today, I think, are agents of discovery and change that are helping that fact to be erased. And so I'm now going to ask my fellow panelists to introduce themselves.
Thank you, Peggy. It's a great honor to be here today. I'm Diana Bianchi. I'm also a pediatrician. I'm a board-certified medical geneticist and a specialist in neonatal perinatal medicine. But my real patient is the fetus. So I consider myself to be a prenatal pediatrician. I'm also a clinician scientist and do work that you'll hear about in a few moments about non-invasive prenatal testing and fetal therapy.
Hi, I'm Chris Wilson. I'm from the Bill and Melinda Gates Foundation. I, too, was a pediatric resident at Boston Children's Hospital a few years before Peggy. Not too many, but a few. And after that, I, like her, became trained in pediatric infectious diseases and stayed on the West Coast for a long time, working at the University of Washington for about 30 years, and becoming very deeply involved in trying to understand fundamental immunological processes underlying pathogenesis of infection and prevention of infection. And then about 3 years ago, I got this extraordinary phone call that I had not given any thought to whatsoever in my life. And that presented an opportunity to do something that was actually the fundamental reason for what I thought I'd entered my career for in the past. That was to be in a position where you might have an extraordinary chance to actually bring resources to bear, hopefully in an intelligent way, knowing that we always make mistakes, but try to learn from them, that would begin to address some of the incredible global inequities that we see in how mothers and children live their lives or die early. And the underlying principle of the foundation, one of our mantras, if you will, is that all lives have equal value. And inherent in that principle is that every mother's child deserves the opportunity to lead their most productive possible life. Now, it's fair to say that that's certainly not true in the world globally nowadays, but I believe that progress has been made and there's much yet need to be done. And I hope that we'll hear a little bit more about that from my colleagues and I here this morning and from questions you in the audience ask.
Good morning. My name is Nawal Noor. I'm an obstetrician gynecologist, and I work at the Brigham and Women's Hospital. I was born in Sudan and lived there in Egypt until I went to high school in London and then came to the States. My father is Sudanese and my mother's American, which is what I always say, thus no accent. I came to Harvard for medical school and have been at the Brigham ever since. I direct the African Women's Health Center, and we take care of women who've undergone female genital mutilation, female genital cutting, female circumcision, whichever way you want to call it. And what we do is we provide culturally competent obstetric and reproductive health to these refugees and immigrants who've come from countries where they've been circumcised, and do reconstructive surgery and take care of their long-term complications. Excuse me. A few years ago, my chairman approached me and asked if I wanted to be the director of a new division on global obstetrics and gynecology, and I gladly accepted. And now we are expanding our work to cover issues like maternal mortality, obstetric fistulas, unsafe abortions, amongst other things. It is such a pleasure to be here, and thank you very much.
Good morning. My name is Mike Green. I'm an obstetrician gynecologist. I work at Massachusetts General Hospital. Noel was one of my residents. And for the past 16 years, it's been my privilege to work as an associate editor of the New England Journal of Medicine.
So the term obstetrics has featured prominently in the New England Journal since the very first issue. But the term pediatrics didn't really make the pages of the New England Journal until about 60 years after that first issue in 1812. And it was used by Sir William Osler first in the pages of the journal, although he was not the one to coin the term. So the panel has selected Dr. Green to give the overview on obstetrics, fetal medicine, and pediatrics to tell us about the issues today for mothers and children.
So Jeff gave me strict instructions that this was not to be a New England Journal of Medicine breastbeating about how great we are, but as an editor, it's hard to avoid a little bit of it. As Jeff already alluded to, although the history of HIV and AIDS only goes back 30 years, midwifery goes back for as long as we have recorded history. You will be relieved, however, to know that I'm only going to cover 200 years of that this morning. And as Peggy just mentioned, the very first edition of the New England Journal of Medicine contained a paper by Walter Channing, who later became one of the founders of the New England Journal of Medicine and the most famous obstetrician of his time in Boston. At the time, Channing, like most physicians, became an expert on syphilis. Much the way Tony Fauci said there are people who are either studying AIDS or will study AIDS. Well, in those days, everybody was either treating syphilis or would treat syphilis. This is Channing, who has an interesting title that has intrigued many. The professor of midwifery and medical jurisprudence. His academic career got off to a slow start when he was expelled from Harvard College for participating in the Rotten Cabbage Revolt that protested the poor food that was given to the Harvard College undergraduates. Despite his expulsion from Harvard College, within 2 years he received an MD from the University of Pennsylvania. As was alluded to by Jeff again this morning, in order to be really credible in medicine in that era, you really needed to go to Europe to study, and particularly if you were interested in midwifery, you had to go to Edinburgh. And in Edinburgh, one of his study mates was John Revere, son of Paul. He came back to Boston and established a practice, and within a year of that became one of the founding editors of the New England Journal of Medicine. In the pages that immediately follow his treatise on syphilis is this note on spurred rye. Spurred rye was ryegrass seed that was infected with ergot fungus, which was recognized at the time as an oxytocic agent. And it was used to help stimulate labor, but it was this note of caution that said that too much of a good thing could result in a dead fetus. And we're still dealing with those issues today. To continue a brief review of Channing's career, he shortly thereafter became a lecturer in midwifery, and in only 3 years went from lecturer to professor. Eat your heart out, all of you academicians in the audience. I have it also on good authority that during that 3 years he didn't have a single NIH grant. The very next year he became the dean of the Faculty of Medicine. And in 1821, he became an assistant physician at the Massachusetts General Hospital. Now, although Massachusetts General Hospital was chartered in 1811, there was this little war of 1812 that got in the way of actually of constructing the hospital. And Channing was actually called to consult on the very first patient that was admitted to the Massachusetts General Hospital, who was a man with syphilis. After he had been in the hospital for a month, he ultimately died in the hospital 9 months later as the result of the treatment with mercury that they prescribed. And in 1832, he became the founder of the Boston Lying-In Hospital right across the street from where we now sit. It's difficult to mention even a brief history of the New England Journal of Medicine without mentioning the paper by Bigelow about the first demonstration of the efficacy of ether anesthesia. And shortly thereafter, you can see that Channing published a paper on the use of ether anesthesia in childbirth. And you'll notice that the publication date was November 18, 1846. The actual date of the procedure was October 15th, 1846. I point this out to our production staff at the New England Journal of Medicine whenever they want to pat themselves on the back for getting things into print quickly. One of the major sources of loss of life in the 1800s was management of placenta previa. And this is an example from a book, from 1843, okay. I'll try a separate laser here. There we go. This is a placenta lying over the cervix, and as you can see, it obstructs the potential progress of the fetus out of the uterus and is the source of massive hemorrhage. J. Braxton Hicks in The Lancet in 1860 proposed a thoroughly modern way of managing placenta previa, which was to reach in, break up all of the adhesions between the placenta and the lower segment of the uterus that would be preventing the fetus from exiting, and then reaching in and turning the fetus, turning the fetus from vertex to breech, tearing through the membranes and basically tamponading the bleeding that would inevitably occur with the use of the fetus, okay? Approximately 50% of the women survived this procedure, and about a third of the fetuses survived it. The first blood transfusion is actually attributable to an obstetrician, James Blundell, who in The Lancet in 1828 reported the use of his transfusion apparatus where he did a direct venesection and transfused straight away into a woman who was dying of postpartum hemorrhage. The first recorded cesarean delivery for the indication of placenta previa was by Lawson Tate in Lancet in 1899. 2 years later, in the Boston Medical and Surgical Journal, we published a paper from Ohio reporting what was apparently the second use of cesarean delivery for placenta previa. And the commentary was that for the purpose of delivering a woman with placenta previa, this was a very unnecessary mutilation. The notion that people have and animals have blood pressure goes back to Stephen Hales, who measured blood pressure in 1733. This is an artist's depiction of his original experiment, where he measured the blood pressure in a carotid artery of a horse by piercing his artery with a brass cannula, and you can see the apparatus that he needed to use to measure the blood pressure in the horse. It was not, however, until the late 1890s that Scipione Riva-Rocci developed a sphygmomanometer as we would recognize it today, which was a air pressure-filled cuff that would permit the occlusion of an artery, and then as the pressure was relieved by palpation, you could guess the systolic blood pressure. Although the association between eclampsia and proteinuria had been recognized for hundreds of years, it was not until Harvey Cushing actually brought a working model of Riva-Rocci's blood pressure cuff back to the United States because he thought it might be useful for monitoring his patients during surgery, that people first recognized that blood pressure was elevated in eclampsia. And it was in this publication in the Boston Medical and Surgical Journal in 1908 that you see the first association of elevated blood pressure and eclampsia and what happened to the blood pressure after the patient was delivered. This from a textbook in the 1940s is a map of the United States, as you can see, which shows the sort of epicenter of eclampsia in the United States was in the southeast. Elliot Jocelyn published this paper in the New England Journal of Medicine in 1915, 7 years prior to the discovery that insulin would treat diabetes. And you'll notice that in this original paper, there were 10 pregnancies amongst 7 women. 4 of those women died attempting to carry their pregnancies or immediately thereafter. It's instructive. One of the women died of diabetic ketoacidosis. One of them died of uremia. One died of tuberculosis. And the 4th woman committed suicide after 2 failed pregnancies. It was sobering to realize that even after the introduction of insulin, approximately a quarter of all fetuses of diabetic women died before they could even be delivered. For those of you who can't read the caption here, something's just not right. Our air is clean, our water is pure, we all get plenty of exercise, everything we eat is organic and free range, and yet nobody lives past 30. It was obvious that we needed to help people and do more than just give them fresh air and clean water to relieve some of the suffering and death associated with childbirth and pregnancy. Not all of our efforts, however, went in a straight line in the right direction. This is one of the first papers touting the use of DES, or diethylstilbestrol, for maintaining pregnancy among women at high risk of miscarriage. And specifically, amongst women with diabetes, it was recommended that preliminary studies of patients with orally administered DES appear to show a decreased incidence of fetal mortality and toxemia. Very shortly after this was published, murmurings began to appear in the literature that maybe DES wasn't really terribly helpful in preserving pregnancy. And one of the sentinel papers published by the New England Journal was this paper from 1971, first documenting what was becoming an epidemic of adenocarcinoma of the vagina that actually started appearing amongst teenagers, 19 and 20-year-olds, who had been exposed to DES in utero. This is a graph of infant mortality in Massachusetts from the pre-Civil War era right through to 2008. So obviously things have changed for the better in many ways, but we're not quite there yet. In recognition of the HIV epidemic, and again, as Dr. Fauci said, if you weren't studying HIV now, you would be studying it later. This was the first paper to demonstrate that treatment of HIV in the mother could reduce the risk of vertical transmission of HIV to her fetus. Prior to this paper, the risk of vertical transmission of HIV was about 25%. With this treatment of AZT, it was reduced to 8%. Recognizing that prophylactic cesarean section could further reduce the vertical transmission from 8% to 2%, was also published in the New England Journal. And subsequently, highly active retroviral therapy has reduced the vertical transmission to almost unmeasurable levels. What are the problems that we still need to conquer, however? One of them is the problem of preterm birth. And this nice graphic conveniently appeared in Nature just a few weeks ago. And you can see that the United States still has a relatively high incidence of preterm birth, comparable to places like Bangladesh. This paper from Lancet, also very recent, is sort of a heat map, if you will, of the estimated preterm birth rates by country around the world. And you'll notice that we are not among the lowest, okay? Canada, all of Western Europe are among the lower rates of preterm birth. And here you can see listed numerically by rank order the countries that contribute the largest numbers of preterm birth. And although our rate isn't the highest because we're a relatively large country, we're number 6 on the list in terms of contributions to preterm birth in the world. This graphic shows very nicely that 40% of all of the babies that die in childhood, defined as by 5 years of age, 40% of all of those occur in the first 28 days of life, largely attributed to preterm birth and infectious diseases, as we'll talk about in a few minutes. These are the breakdown, complications of preterm birth, intrapartum complications, pneumonia, anomalies, tetanus from improper treatment of the umbilical stump, and then diarrheal diseases. Conveniently, just a week ago in the Boston Globe, there was this article about Ugandan women protesting the rate of maternal mortality in Uganda. In Uganda, 100 women per week die in childbirth. This displays some of the realities of childbirth in Africa. One of the questions that was asked recently was what percentage of births are attended by skilled attendants? And here's the answer for some of these countries that I've just pulled sort of at random to put on the slide here. But the definition of what a skilled birth attendant is highly variable and could include traditional birth attendants who are quite literally illiterate. This is also a fairly stark statistic, which is that you can see from the developed nations to the lower and middle income nations, the annual maternal mortality toll for the country. This is that standardized per 100,000 births. And this column is particularly striking. That owing to both the risk of maternal mortality and the lack of contraception, you can see that when a woman is born in Afghanistan, she has a 1 in 8 probability that her life will end in a reproductive event. This is maternal mortality map of the world, compiled by the Gates Foundation and recently published in Lancet. And one of the things that I'll point out is that you'll notice that this is the rate of rise or fall in the maternal mortality rate around the world. And you'll notice, much to everyone's chagrin in the United States, that it appeared as though our maternal mortality rate had actually risen from the last survey to the current. And there may be a number of reasons for that, and we might address them during the discussion period. Even if you survive your childbirth in Africa, you are at risk of this problem, which is a vesicovaginal fistula. From a lengthy obstructed labor, there is necrosis of the vagina and the bladder from pressure of the fetal head from an obstructed labor. And these women have a hole in their bladder. They cannot control their urine. They leak urine constantly. They are usually left by their husbands and ostracized by their family and their village. Their life is pretty miserable. Another problem that is not entirely unique to Africa, but certainly of great import on that continent, is the problem of female genital mutilation. Also goes by the name of female genital cutting or circumcision, as Noel mentioned a minute ago. And you can see some of the problems that occur with increased frequency among usually young girls who have undergone this procedure prior to 5 years of age. There has been considerable attention to this problem in the literature in recent years, especially as you can see here in these papers in Lancet. The price for our reduced mortality and improved outcomes in the United States has, as well as the rest of the developed world, has been a skyrocketing rate of cesarean delivery. And the big news in 2010 was that for the first time, the cesarean delivery rate in the United States did not rise year on year since the nadir down here in about 1995. As the result of what's perceived to be an undue rise in the cesarean delivery rate, there has come about in the developed world an increasing impetus for women seeking alternatives to childbirth in hospitals, which is highly technological and associated with a high rate of cesarean delivery. And this has been an increase in home births. This was a case that made the newspapers around the world of a young woman in Victoria, Australia, who was a very ardent home birth advocate, who delivered at home and herself died of hemorrhage at home before she could get to hospital. One of the very exciting advances in recent years in the world of obstetrics has been the tremendous advance in prenatal diagnosis and the ability to diagnose chromosomal abnormalities and indeed single gene defects prior to birth. This was probably the first paper demonstrating that fetal DNA, cell-free fetal DNA, could be found in the maternal plasma by demonstrating Y chromosome segments in the circulation of pregnant women carrying male fetuses. Subsequently, a much larger body of work has demonstrated that at even 13 weeks of gestation, you can find fairly large quantities of fetal DNA in the maternal circulation. And based upon this fact, it is possible to separate fetuses with normal chromosomal constitutions from fetuses that have abnormal chromosomal constitutions. And just to give you an idea of how quickly and the accelerated pace of the developments in this area, this paper demonstrating segregation of the number 21 chromosome from maternal circulating cell-free DNA in November of 2011, followed within months, demonstrating that not only could you find trisomy 21, but trisomies 13 and 18 as well. And very recently, just last week, in fact, in Science Translational Medicine, there is a report of the non-invasive whole genome sequencing of an entire human fetus in utero. So, it's the dawn of a new era of prenatal diagnosis and obstetrics for the United States and the world. Thank you.
Thanks, Dr. Green, for that great review. I think we've all heard some figures that are astounding in some cases because they're appalling. And so I think our panel is going to tell us about what we can do. And we want the essay winners to be particularly avid in their interest. So let's start with the issue of preterm birth. As we saw amongst industrialized nations, the United States does not rank at the top in terms of a low incidence of preterm birth. People suggest, recent estimates, as you saw in Dr. Green's introduction, that complications of preterm birth are the second leading cause of global childhood mortality for children under 5, the first being pneumonia and diarrhea, perhaps prior to the advent of the new rotavirus vaccines, with the second leading cause. But our understanding, our knowledge of the underlying mechanisms and available interventions that target these causes would address really only a very small fraction of the burden, maybe only 20%, even if delivered at scale globally. So I'm going to start with Dr. Wilson from the Gates Foundation. Other panel members will pitch in and ask, why is the investment into research to understand the causes of preterm birth and identify new solutions for this problem so low relative to the attributable burden of disease?
Yes, thanks, Peg. I think that it's kind of an appalling issue for everybody. When you look at the rate of preterm birth in the United States as well, you look at the relative investment by the NIH, for example, in research as to the cause of preterm birth, it's I guess paltry would be a kind word. And I think it's a little hard to understand. Obviously, some of that in this nation is related to the fact that preterm birth is caused by iatrogenic events, such as assisted reproduction. But many of the problems that are global contribute to the preterm birth problem here. So, we have had good conversations with the NICHD on this. The new NICHD director, Alan Goldstein, is particularly interested in this problem in trying to put together RFPs to, one, explore the underlying basic problems. And we recognize that it's not a single common problem. The difficulty with that kind of work, of course, is it's not going to get you to a solution tomorrow. It's research that has to explore and discover pathways and understand them better before you have any potential solutions that you can put into place. Nonetheless, I think the lack of investment in this area over decades has put us in the situation in which we find ourselves. So we got, there is an interest to contribute funds to this from our foundation, from USAID, and from NIH, and other agencies like the March of Dimes that may be able to shed some new light on this problem. Now, the other option that may have more near term is to say, okay, let's take that 20 to 30% of those interventions, progesterone, for example, or equivalent pessary or something like that, might delay preterm birth. And if we could scale that, maybe we'd gain 20 or 30%. And so I think that's an issue still worth doing. The challenge that occurred in this country was when progesterone was demonstrated in a properly done trial to reduce the rate of preterm birth. One, the result was marginal. Two, the result was only seen when you had a high-resolution measurement of the length of the cervix. And both of those are potentially problematic for the developing world. And then the first and worst thing that happened, of course, is once the progesterone was formulated in a way that was consistent, they raised the price 1,000-fold and made it highly unaffordable, even though the NIH had paid for the research. That's unconscionable, but that's a different issue. So I do think it's important for us, that is collectively, to try and identify how we can scale to determine whether there are situations where direct administration, in the absence of the same sort of cervical length assessment as was used in that study, might still be of some value. And if so, that's something that can be deployed and may have benefits straight away. So I think that we need a two-pronged attack, both focusing on more near-term solutions and on trying to understand the underlying biology better. And the underlying biology, again, is going to be multifactorial. There is undoubtedly a component of infection and inflammation that may dominate in mid-pregnancy and up until, I'd say, 28 or 30 weeks. It may be a larger fraction in some parts of the developing world. It certainly contributes here. But no one has taken that knowledge, to my knowledge, and turned that into a practical solution. Again, there's upstream research in that area looking at things such as the vaginal microbiota, which may well be a contributing factor to this inflammation-related piece. But again, how that's made into actionable intervention has yet to be reduced to practice, to my knowledge. So I think we need both of those kinds of approaches ongoing. And some of those will be beneficial for the developed world. And many of them will have a broader benefit if they can be scaled and delivered for the developing world.
So the coalition is forming, as Dr. Wilson mentioned, the Gates Foundation, the NIH, the Burroughs Wellcome Foundation, the March of Dimes. All of these organizations are leading research campaigns for discovery of mechanisms of preterm birth. What do our colleagues in OB think might be some of the highest value avenues of research that are needed to address this problem?
Well, certainly the whole problem of preterm birth could easily be a multi-day symposium in and of itself, and will be, sponsored by the March of Dimes and the Burroughs Wellcome in December in California. You're never going to get very far with preterm birth if you look at it as one big thing and of one etiology. And there are actually some small victories in the preterm birth story. So first of all, I think that globally all preterm birth can be looked at as very early preterm birth and later preterm birth that have different sets of etiologies. From the later preterm birth, there is some good news. Some of the good news is that some of those preterm births would have been fetal demises had obstetricians not recognized that they were dealing with sick fetuses and put those fetuses in the care of our pediatricians. One of the great things about being an obstetrician is that we always have pediatricians to watch our backs and take care of the very premature babies that we deliver. And contrary to obstetricians who haven't done a very good job of reducing the risk of preterm birth, pediatricians have done a spectacular job of improving the outcome for the very preterm babies that we deliver. So there is some good news in the story in that there is a net increase in survival. And if you look at perinatal mortality, it's monotonically been falling in the United States, even as the preterm birth rate has been rising. So there is a little bit of good news. Furthermore, the very preterm birth that I alluded to seems at the moment to be a sort of elusive biological bedrock that we really haven't changed. That rate is somewhere on the order of about 1.8% of all pregnancies that are delivered prior to about 32 weeks. And we really haven't done much to change that. Most of the change in the overall preterm birth rate has come in the range of gestational age from 32 to 37, which is the WHO definition of preterm birth. So it's certainly complex, and solutions that will work for one are unlikely to work for another. One of the things that Chris Wilson just alluded to is the assisted reproductive technology epidemic, if you will. In the United States, 1% of all babies born in the United States now are born by as the result of assisted reproductive technology. That number in several countries in Western Europe is 2%. 1 in every 50 babies in Western Europe is born as the result of assisted reproductive technology. One of the things that we know is that you're far more likely to wind up with a multiple gestation if you start down the assisted reproductive technology road, and of course, those contribute very substantially to the preterm birth rate. However, even when you isolate singleton babies as the result of assisted reproductive technology, those women too, and those pregnancies too, still have a greater probability of premature birth. The reason for that is not entirely clear, and it may have something to do with the indication for the procedures of assisted reproductive technology, that there is something about subfertility that also results in an increased risk of preterm birth. Either way, the argument would be made that without assisted reproductive technologies, those couples wouldn't have an opportunity to have children, preterm or otherwise. So we have to be careful not to demonize the assisted reproductive technology people for their contribution to the overall incidence of preterm birth in the United States. There are many more nuances. Noelle, you want to?
So bringing it to sort of the global health perspective, I think one of the biggest challenges is, are we talking about there is assisted reproductive technology occurring in these areas, and in fact, a lot of these end up with very large numbers of fetuses, and so that also impacts preterm birth. But also, I think part of the challenge in a developing world is that we don't have a great idea of a woman's prior history, her obstetric history. And I think one of the things we're trying to determine is if we can identify the woman who has had a prior history of preterm delivery, we can perhaps prevent preterm delivery in her subsequent pregnancies. But by the time she reaches a health center, it may be too late. And so there are some really good cost-effective measures or very, very little cost-effective measures that can help us in decreasing the preterm delivery rate. I think the other aspects, especially when it comes to progesterone, here in the United States, there's been the challenge of educating the health provider to start giving patients progesterone, and we don't like change. And although the data may show it in the New England Journal of Medicine or the Lancet, our behavior takes a little while, and so there's a lag time. So as health providers, we haven't been upfront in offering patients progesterone. When it comes to offering progesterone in developing nations, as you had mentioned, cost is going to be a problem. So I can see that this is going to be a long-term issue when it comes to developing nations, and how do we go ahead and decrease that number?
So we've talked about preterm birth, defined really as birth before 37 to 38 weeks in utero. And one of our panelists, Dr. Bianchi, is really a fetal pediatrician. A number of years ago, she made a remarkable observation, and that was that in the thymuses of mothers who had delivered male infants, there were male cells. Now, that told us an amazing amount about the communication between mother and fetus. It's not all one way. And so, Dr. Bianchi, what's going on in that area? The fetal medicine, from the standpoint of the fetus in utero, what's new?
Okay, now, he thought it would be a good problem for an impressionable first-year medical student to go ahead and just develop this blood test, because it was a very important problem for he and his wife. And that was in 1976, and we really solved the problem around October 24th, 2011. So as of that day, non-invasive prenatal testing using a blood test became clinically and commercially available. So my message to the essay winners is be persistent, because what happened in between is incredible advances in technology, things that we could have never fathomed back in 1976. We've seen in prenatal diagnosis screening techniques, invasive techniques, procedures such as amniocentesis and chorionic villus sampling that Dr. Green performs. But we're really moving away from looking at chromosomes under a microscope and going to an era where we're using DNA to analyze everything. And today, literally, you can take a blood sample from a pregnant woman in which there are fragments of fetal DNA mixed with her cell-free DNA, and you can use next-generation sequencing to count the number of molecules from all of the chromosomes involved. So we're not only diagnosing fetal problems, in fact, indirectly, we're diagnosing maternal problems as well. There's been tremendous interest in next-generation sequencing and how that's going to affect medical care. And sort of what I see is this divergence between significant problems in the developing world, where malaria is one of the biggest problems and kills, many more children than anything else. And then you see the developed world, where you've got the mommy blogs and you've got people on the internet, who want absolutely every possible test that they can have so that they can have a perfect child. And that's the world that we live in and we try to navigate. So it's a very, very interesting time to be practicing medicine and also to be the recipient of advances in technology that occur elsewhere that we're able to apply to our patients. On the other hand, this does raise many ethical issues, and I couldn't help but think when I was listening to Bob Massey that some of the testing that's done using cell-free fetal DNA is done for the purpose of fetal gender. And in some cultures, it's done because people want a boy, and in other cultures, it's done because people want to avoid a boy if a boy has a risk of a genetic condition. So I was thinking about Bob Massey's parents, and that technology wasn't available when he was in utero, but how can we use this technology in a positive way to ensure that every child is born healthy and wanted, which is part of the mission of the National Institute of Child Health and Human Development. I think the future really is in using prenatal diagnosis as a way of starting our treatment in utero. And just last year, we had an important paper published, not with my group, but the world had an important group published in the New England Journal of Medicine about fetal treatment for neural tube defects, looking at the relative advantages of performing surgery once you knew from ultrasound that a fetus had a neural tube defect. And the study showed that there were distinct advantages, but there were also some disadvantages as well. But that's where the future is for providing therapy and trying to avoid some of the complications ahead of time before the child enters the world and becomes a patient of the pediatricians.
Well, let's shift gears a little bit and talk about nutrition during pregnancy. For example, in the developed world, we're really grappling with the obesity epidemic, and that affects fertility and perinatal mortality and prematurity and maternal morbidities. But we also have issues of obesity in the developing world. And I think some of the obstetric members of the panel, I think Dr. Noor, Dr. Green, can talk about obesity both here and around the world and what it's doing, how it's changing perinatal medicine.
Well, yes, obesity, you'd have to be living in a cave not to know that in the United States, we are getting fatter as a country with every passing year. And among women who want to become pregnant, obesity is a deterrent to fertility. Among women who do become pregnant, it's a cause of a number of major problems. As we know, obesity in and of itself is basically a chronic inflammatory state. And that chronic inflammatory state has a number of consequences. It's clearly associated with an increased risk of first trimester spontaneous abortion. It's associated with an increased risk of a variety of congenital malformations, most prominently neural tube defects and congenital heart defects. It is associated with an increased risk of preterm birth. It's associated, ironically, with increased incidences of both very big babies and very small babies. And it's also associated with an increased risk of late fetal demise, likely due, again, to this chronic inflammation that is probably not good for placentas. Should a woman, an obese woman, reach term with a healthy baby, it turns out obesity in and of itself is also a risk factor for cesarean delivery. And then should an obese woman require a cesarean delivery, the obesity is a risk factor for infection, for venous thromboembolic events, and for mortality. So it's a major problem in the United States and the rest of the world. We are not unique. The rest of the world, most of it is a little bit behind us, but not too far behind us, unfortunately. I'm not sure that forbidding the sale of big gulps is going to solve the problem.
So worldwide, it's interesting because I think if you think of a developing nation, obesity isn't the first thing that comes to mind. I think most of us will imagine that, poor nations probably have malnutrition as an issue, and that there are famines and there's issues with food security, and if there is a war, then clearly there's going to be issues of malnutrition again. So the concept of obesity in a developing nation is foreign to most of us. But if some of you have ever traveled to Nigeria, for instance, or Egypt, India, and even parts of Brazil, you will recognize that obesity does occur there, and it is becoming an increasing problem in developing nations. And so when you have a health system that is already struggling to survive on the infectious diseases and some of the non-communicable diseases, now we've added obesity to the equation, and so that increases the risk for diabetes, cardiovascular disease, hypertension, not to mention the problems that we just heard about regarding pregnancy and obesity. There have been studies here in the United States where it's very clear there's a correlation between poverty or low socioeconomic status with obesity. And that, in fact, if you look at a mother and she's making choices, food choices, she will probably choose bad food for herself and better food for her children. And that's the same type of choice that a woman in Egypt will make. So she'll switch over from giving the child, she'll give the child good food, and she'll have the French fries. You also notice in the United States that the grocery stores that are close to the urban areas, the poorer urban areas, don't necessarily offer great foods, right? So they don't have the high grain, but rather they'll have sugars, highly processed foods, a lot of fatty foods. And so the diets that poor people are faced with really do help them gain weight. And those are similar problems in developing nations. And one of the things that I saw very, very clearly when I was growing up in Sudan and Egypt is that Wendy's and Burger King and McDonald's were coming in, in massive doses. And in fact, that the poor Egyptian who was very used to eating smaller sized foods were suddenly given larger and larger portions. So obesity is becoming a big problem. On the other side, there is a cultural aspect to obesity. So very much back in the Victorian era where it was wonderful to be voluptuous, in the United States and Western world, now it is better to be fit and firm. That concept hasn't changed in many of these countries. And I used to remember going and visiting my family members in Sudan, and they would look at me and say, "What's the matter with you? Why are you so thin? Are you sick?" Because, the more voluptuous you were, the more attractive you are to the male species. And so being rounder is acceptable. Not only is it sort of more attractive, but it also gives an indication of wealth. So if you are able to eat or consume food, you are demonstrating to your society that you are a wealthier person. And finally, I think that in time, this concept of dieting and exercise is starting to shift in some of these areas. And you can imagine that even in Saudi Arabia, they have gyms now that are for women only, and they are starting to push it. So we're seeing that the philosophy is changing, but it is changing slowly.
Yeah, I just wanted to point out that obesity is a transgenerational problem. So whereas when I was in training, obstetrics and pediatrics were somewhat siloed, we now recognize that the in utero environment is extremely important. In fact, one of the most important things that you need to know about yourself is how much you weighed when you were born, because that simple fact indicates the kind of in utero environment you came from. And if you are coming from an environment in which the mother was obese, as Dr. Green said, you could be either large or you could be very small, and some of the increase in prematurity is coming from this increase in obese pregnant women. But the environment in which you develop really has a profound effect on your long-term health. And the environment, there's a whole field of medicine now that is known as the developmental origins of health and disease, or the Barker hypothesis, where if you have been starved in the womb, this is one of the single greatest risk factors for you to develop cardiovascular disease as an adult. So we can't just look at these problems as a problem of adulthood. This is a transgenerational problem in that we are programming these children for health problems, even if they had the most perfect diet after being born, and we know that's not the case. So this is a complex, multi-generational issue that is going to have profound implications for health and world economics.
Yeah, I mean, I think this is a key point. An absolutely key point. I mean, in fact, in most of the very low-income countries, there's actually still a very large fraction of children who are stunted and undernourished from conception up until about 1,000 days of age. In fact, if you look at those growth curves, they start out small and short, and then there's a deceleration over the first 6 months, typically reflecting both poor amounts or quality of food, but also the prevalence of enteric infections and other things that lead them to assimilate that nutrition poorly. And those children are basically, after the first 2 years of life, they're never going to catch up in their linear growth, but they might catch up in their other growth, meaning they could become short, fat little people, and we'd have the worst of both worlds. And I think that's a particular risk in South Asia, where there's a high relative body fat index in South Asia. And intervening during that in utero period, or filling out what we need to intervene in utero in early life, is absolutely crucial. I mean, as you alluded to, there's the Barker hypothesis, the Dutch hunger winter, if you will, experiment that the Nazis placed on them, where they were starved for a period of time, and they clearly had an imprint on their future growth. We're somewhat reassured by some recent data we've seen from a large study that's coming out of Oxford, supported by the Wellcome Trust and us, where in essence what they've done is gone into a handful of well-to-do countries, like the UK, but in a number of low-income settings. But in the low-income settings, what they did was say, let's go see what happens in a low-income setting, but in the upper echelons of that low-income setting. And we're going to do weekly ultrasounds. We'll plot the uterine growth of the children, and to determine, is it just that people living in these settings are just going to be short? Well, that's just the way it is. But at least based on relatively similar genetics, but having lived in a more resource setting for a relatively short period of time, their intrauterine growth now pretty much tracks the intrauterine growth curves for North America and Europe. So I do think that we can't conclude that a stunted physiology in utero is the normal state for those countries. that stunted physiology is the exact thing that the Barker hypothesis or the Dutch-Unger-Winter would propose, is going to make them be short in the first year or two of life and be at incredibly higher risk for obesity, type 2 diabetes, and so forth after that. An astounding figure, at least it was astounding to me, maybe that was my naivete, is that if you look at the incidence of TB in China and let's say India, about 35% of the cases are in type 2 diabetics. That's almost as big a risk as HIV. It's unbelievable. So there's a situation where we clearly want to address the growth and nutrition of these children now. But one of the worst things we could do in trying to do so would be to take a group of stunted, undernourished children from conception to the first 2 years of life and in fact convert them into a obese type 2 diabetic who's at more risk for TB in countries that have lots of TB. So I think that, it isn't just simple, and there's some thoughtful planning and attention to how things proceed will be important.
So before we open to the audience, let's talk just very briefly about some interventions that do work. And I'm talking about vaccines delivered to the mother. For example, we know we can prevent neonatal tetanus if we immunize the mother, and her antibodies will then cross the placenta, usually in the 3rd trimester of pregnancy, and neonatal tetanus can then be prevented. We also know from recent studies in Bangladesh and now replicated in Canada that influenza immunization for the mother has benefits not only in preventing the flu, but in allowing her to give birth to a healthier baby who's protected against influenza for those first 4 to 6 months of life, but who weighs, on average, several ounces more at birth. So a healthier baby in at least 2 ways: protected against influenza and weighs more at birth. And yet we find that there's a lot of difficulty with vaccine policy, for example. Big Pharma is reluctant to develop vaccines for pregnant women because of liability issues. And in the developed world, our world, many women are reluctant to be vaccinated in pregnancy. In the developing world, we have problems of delivery. So just to conclude, let's ask our panel, what are some policies, what are some innovative approaches to vaccine acceptance for pregnant women in the developed world and vaccine deployment for pregnant women in the developing world? Who wants to start? Chris? I bet the Gates Foundation is very invested in
this is very high on our list. Flu and tetanus are sort of no-brainers. Even our country, the most perhaps risk-averse in terms of vaccine licensure, have agreed that those are useful and should be used. The only thing that's appalling in this country is the really poor uptake, especially of flu vaccine. I think in addition to the ones that you mentioned, Peggy, another one, and perhaps one in the future that would make a lot of sense there, would be acellular pertussis vaccine, because again, the greatest morbidity and mortality is in the first few months of life in a child who becomes infected. And should we get one, a respiratory syncytial virus vaccine would have the same profile as a pertussis vaccine. I must say I've been somewhat encouraged lately by conversations we've had with a couple of the big multinational vaccine manufacturers that, hey, if we'll stand by their side and go to the regulators and talk to them, they're actually willing to do this. They can see that there's some benefit to that, and they just think they need other people standing by their side so that that will diffuse some of the sense that it's self-serving on their part to try to get these vaccines available for use in pregnant women, where at least for the 2 vaccines we mentioned and really for acellular pertussis, the evidence of safety is pretty outstanding, and no reason to believe that it's going to be deleterious. And as you say, this somewhat surprising benefit seen with the flu vaccine studies in terms of overall benefit and not just influenza benefit suggests that perhaps more deleterious effects of having influenza going around in the mother or the child in the first months of life were happening, and that this benefit is now being accrued by the administration of the vaccine. So I do think it's an area where we need to advocate for something, and we need to support the development of vaccines that can be used in that context, for which that's the most effective way to deliver it, because the risk group is in the first few months of life where we really can't immunize the child quickly enough to provide the protection for the most vulnerable period.
Any comments from our obstetric colleagues on uptake of how do you counsel pregnant women about vaccination?
One quick comment is that in the United States, it's very clear, research has shown, that getting a pregnant woman to accept influenza vaccine, for the most part, is not terribly complicated. Her obstetrician just needs to recommend it and provide it. Organized obstetricians in the United States have actually stepped up to the plate to stock and provide influenza vaccine in their offices and recommend it and administer it to pregnant women. I think that the other piece of the resistance to vaccinations in general has been a sort of an internet or other world that somehow envisions grave consequences, unintended consequences, to vaccinations of both pregnant women and children in the newborn period and in childhood. Everything from autism to I don't know what, is alleged to be associated with early vaccination to either mothers or children. And we all who don't believe that to be true need to be sure that we make our voices heard and try to make people believe the science that there is no relationship between these alleged adverse events and the administration of these vaccines that have been administered literally to tens of millions, if not hundreds of millions of people.
Okay, thanks. I think we'll open it to the audience now. The panel, as you can see, has a wide range of expertise: prematurity, maternal morbidity, etc. Yes.
Thank you very much. My name is Peter Kaminsky. I'm a second-year medical student at Brown University. It's inspirational to hear about all the new innovations in terms of dealing with pregnancy complications, but I was wondering if anybody on the panel, and perhaps Dr. Wilson, given your experience with the Gates Foundation, could speak to the importance, the impact, and the delivery of family planning services and education in the developing world in particular, and also, of course, in the West as well. Thank you very much.
Well, I'll open, but I'm sure my colleagues will have things to say. Family planning is absolutely crucial in all respects. And we do know that when women have access to family planning, they space their children farther apart. And that in and of itself makes a better outcome for their children, because they're going to get better nutrition, they're going to get better care. So if that was the only thing that occurred out of family planning, that spacing increased, that alone would be a benefit. But it really also empowers women, it empowers their families to say, what is the appropriate size for my family, such that I can make sure that I can give them the best circumstances to lead a full and productive life. And I think that is an area that, one, is very regional specific. What is acceptable or preferred family planning tools is highly dependent on countries. Some countries like implants, some countries like long-acting injectables. The U.S. happens to like to take oral contraceptives. So you have to really be willing to play within what is the acceptable belief system or favorite system for that country, and then try to develop products that are, one, affordable, two, available, because lack of availability has been an issue, and three, scalable and made available. The foundation has upped its interest in investing in contraceptives this year. I think you'll hear another major address by Melinda Gates within the next month. This is a cause célèbre for her, and one that did a little soul searching. She's Catholic by birth, and she's just decided that she can't hold the tenets, official tenets of the Catholic Church, and fulfill the mission that she believes she has, in ensuring that women have access to appropriate family planning tools. So that's, I think that's our perspective. It's a very important part of our work.
Thank you.
If I can just add to that, I think that if there's any take-home message about family planning is family planning saves lives. It saves the life of a mother and it saves the life of that child, or the subsequent child. And as as was mentioned, if we can do birth spacing, that already impacts the life of that subsequent child, and it will prevent them from having preterm delivery. If we can offer family planning to adolescents, so they can not start reproducing until after the age of 18 and preferably after the age of 20, then we can potentially save that girl's life, because maternal mortality is so much higher on somebody who is pregnant under the age of 18. And child marriages and child pregnancies do occur. In fact, I just read something recently where there was a 13-year-old girl who underwent a C-section. So family planning saves lives, whether you're going to talk about oral contraceptives, injectables, long-acting, the ones that stay under the skin for a year or two or more. But the other aspect of family planning that some people are not comfortable talking about are unsafe abortions. If you don't have family planning and you have unsafe abortions, then the death rate can go up to 70,000 deaths of women per year. A very, I think, eloquent study on this was Romania. So in 1996, there were 20 women per 100,000 that died, and at that point, abortion was allowed. That law got changed, and within 10 years, the death rate went from 60 per 100,000 to 150 per 100,000. When they reversed that law, within 1 year, we dropped the death rate to 20. And then now in 2002, it went down to 9. So clearly, allowing unintended pregnancies occur, that's a reality. And I think that those sorts of discussions need to occur.
Yeah, if I may, one of the cruel realities here also is the fact that long-acting reversible contraception can be produced extremely inexpensively, if it weren't for concerns about licensing and liability and such. They could be produced extremely inexpensively and distributed in areas where they don't have a lot of money to buy them. But it is a cultural problem to get women to accept them. And just to echo what Noel said, in 1971, the last full calendar year before Roe v. Wade, there were 36 deaths in the United States due to unsafe, illegal abortions. In the most recent 10 years in the United States, for which we have data, there have been 2 mortalities in 10 years. So, yes, it's a hugely important issue.
So a quote that resonates with me on this issue is, if you educate a man, you educate an individual. If you educate a woman, you educate a family, a nation, and a generation. And there may be questions on that quote, but we'll take the next questioner now.
Thank you all so much.
Go ahead.
I was wondering if members of the panel would elaborate on the risks and benefits of prenatal genetic testing in developing countries, and also whether changes in cultural attitudes, mores, are affecting the way in which prenatal genetic testing is being applied.
I couldn't hear your question. Your question was in developing countries.
That's right.
Okay, yes. Well, there is interest. Resources are different. However, there are incredibly creative approaches to reducing the costs of prenatal diagnosis. The biggest challenge in Southeast Asia and in India and even the Middle East is thalassemia, beta thalassemia. So there have been some very interesting point of care approaches that are very cost effective. And there are, even in the Middle East, I'm editor-in-chief of prenatal diagnosis, so we're an international journal, we see approaches that have been taken in other parts of the world. And you wouldn't think of the Middle East as necessarily being the place where they would have internet-based education programs for carrier screening and prenatal diagnosis of beta thalassemia. But in fact, there are some remarkable programs that are far superior to what we do in the United States. So I would echo what Dr. Wilson said, which is that there are very specific regional attitudes and that are also influenced by resources. Africa, for example, there are attempts at having prenatal diagnosis in Africa, but they are very limited and mainly focused on urban areas. As I said, some of the bigger challenges relate to infectious diseases. But I think we're really seeing the effect of the internet and how the internet can educate people, and how the internet can be used to bring people to environments where they can get prenatal diagnosis if they desire it. But I would say that India, parts of rural China, South America, and certain parts of Africa are developing centers of prenatal diagnosis specifically for genetic disease. So it's happening. It's happening slowly. It's certainly not happening at the pace of the United States, where there's literally another major paper every week on some form of non-invasive or prenatal genetic screening. But it is happening. And again, I think everybody worldwide wants to have a healthy family. And so people are using new resources to achieve that goal.
Thank you.
If I may bet to widen your question out a little bit from not just prenatal genetic diagnosis, but prenatal diagnosis, there is a dark side to prenatal diagnosis, which has been occurring since the development of ultrasound. And that has led in many countries to a huge deficit of female persons. Okay? So that in some cultures that don't value female children, the ratio of female children to male children has dropped to about 880 to 1,000. Okay? And that's the result of prenatal diagnosis using ultrasound, which many countries have outlawed, but nonetheless, there is a burgeoning black market in that kind of prenatal diagnosis.
Thanks. We've got a number of questioners. Let's do you first and then move to the other side of the room. So,
Thank you.
My question.
Wait, I'm just going to do, she was in line first, I think, and then we'll come over there.
And my question's very quick. I'm Cindy Cooper. I'm a OBGYN from New Hampshire, president of the New Hampshire Medical Society. And I just wondered, has the premature delivery rate changed at all since the 1930s? With all our interventions that we do, has it actually helped have premature birth rates gone down?
So yes, the premature birth rate has changed, but it's gone up and now down. Okay? So that from the 1930s, the premature birth rate was about 9%. That rose to about 12.5%. That peaked in about 2006, and it's now coming down a teeny bit. So the answer is yes, it has first risen and now going down. But as I mentioned a few minutes ago, despite the fact that the premature birth rate has gone up and then come down, the overall perinatal mortality rate has steadily fallen.
Okay, thank you. Thank you.
Thank you. I'm Arnold Relman, former editor of the New England Journal. Many people here probably are aware of the fact that politics has recently intervened in what most of us would consider to be good medical care by physicians, particularly obstetricians. 2 or 3 weeks ago, Dr. Green And my wife, Marcia Angel, put a piece in the USA Today which said, why aren't obstetricians, why aren't physicians objecting to state governments that are telling doctors how to practice medicine, telling them what they can tell patients and what they can't tell patients and what they must do and what they must not do. My question, I guess, is to Dr. Green. What's been the reaction of your specialty since you and Marcia called attention to this outrageous interference with the practice of medicine by some politicians in some states?
Well, to be clear, let's just talk about a couple of the things that we were concerned about and exercised about that caused us to put that piece in USA Today. Some of the legislation at state levels that has been proposed and in some cases passed have done such things as to require physicians to counsel patients falsely about the potential consequences of pregnancy termination, number one. Others have been proposed that would hold physicians harmless for lying to their patients about the conditions of their fetuses and pregnancies if those physicians thought that in their judgment the patient might use the truth to result in a pregnancy termination. So we thought that those particular interventions were particularly egregious in getting between doctors and patients. To answer your question as to what has been done, to the extent that the American College of Obstetricians and Gynecologists represents the majority of obstetricians and gynecologists in the United States, the president of the college was very quick to write a letter to USA Today and then to follow it up with an op-ed piece in the New York Times saying that the college was firmly opposed to such egregious intervention in the doctor-patient relationship. The final sentence of one of those was, get out of our examination rooms, basically. I think that the majority of obstetrician gynecologists are very disturbed about this recent trend. I wish I could say that I saw a soon and easy end to it.
Thank you. So we have a question back there, and then I'll come over here.
I'm Steve Schroeder from UCSF, and I'm a member of the editorial board. Arthur Conan Doyle once wrote a short story about the dog that didn't bark. And there's a risk factor that affects all four of these conditions that we haven't heard about yet, and that is smoking. Smoking now is probably the biggest killer of people with HIV. It's one of the major causes of premature death. Exposure to secondhand smoke may be a factor in the development of wrist cancer, and clearly is a major factor in heart disease. Smoking among women is actually more common in the developed world because smoking in many of the developing countries isn't a sanctioned act by women. So I wonder if you could comment on how well we're doing on getting women not to smoke, pregnant women.
So we're doing better in some places than others. In Massachusetts, we have the lowest incidence of smoking in pregnancy anywhere in the United States. That's down to about 14%. In other states, for example, West Virginia, it's about 35%. It's a patchwork quilt in the United States. In other countries, in the European countries, they haven't gotten the message at all yet. And smoking amongst pregnant women in many European countries is still in the 40–50% range. But you're absolutely correct that it is a major contributor to preterm birth. It's associated, for reasons that we don't understand, with placenta previa. It's associated with antepartum hemorrhage, even aside from placenta previa. And it's also a strong risk factor for preterm premature rupture of the membranes. All of those are major contributors to preterm birth, and especially very preterm birth. So as you're well aware, however, it's also very difficult to unscramble and disentangle that from the fact that it is far more common amongst poor women than it is advantaged women. There are a lot of other things going on in the lives of poor women that could also contribute to the increased risk of preterm birth.
When you're just thinking globally, though, I think you are accurate in stating that in developing nations, for cultural reasons, that men smoke more often than women. The problem, however, is that secondhand smoke is very high when it comes to smoking in the homes, smoking in restaurants, smoking in public areas. So if any of you have ever gone to Egypt, for instance, it doesn't take long before the smoke hits you right after the coming out of an airplane. So there have been some efforts to try to reduce smoking cessation or improve smoking cessation. The problem is that governments haven't really been working very hard on trying to allow for safe zones. I'm starting to see more and more in areas that there are small little boxes of, probably 10 people in that little box smoking cigarettes. So you can see the smoke there, and then the door opens, and the door remains open, and it goes into the rest of the room. So I think we need a lot of work on that. I do think women and children are exposed to smoke much more frequently in developing nations than they do here.
Okay, thank you. Dr. Drazen has said one more question, so you're up, and maybe we can sneak in Dr. Engelfinger right at the end. He says no. Sorry. Oh, my gosh.
I'll sit down.
And this question comes in on the New England Journal of Medicine's Twitter feed. In Indonesia, the top problem and cause of maternal death is eclampsia and preeclampsia. What can be done about it?
Well, eclampsia and preeclampsia is actually one of the huge successes in the advantaged world, and I didn't have time to talk about it in my 20-minute presentation there, but it was the recognition that elevated blood pressure was the precursor, the earliest obvious physical sign to eclampsia that actually was the impetus for developing prenatal care. It wasn't prior to the 1920s, there was no such thing as prenatal care. When a woman went into labor, the obstetrician showed up, and that was it. But it was the recognition that eclampsia could be anticipated and prevented that was the impetus for the development of prenatal care. Subsequently, obviously, prenatal care has grown tremendously. To specifically answer the question, other than prenatal care and anticipating the development of eclampsia, the only thing that we've done, to be perfectly honest, that has been efficacious is the use of magnesium sulfate. And magnesium sulfate prevents eclamptic seizures, and it reduces mortality associated with eclampsia. It's very inexpensive and can be done by intramuscular injection in very low resource settings.
Thank you. I want to thank the panel for the interesting discussion. Peggy, Diana, Chris, Noel, and Michael. This concludes our morning program. We have arranged to feed you lunch. If you exit the auditorium either on this floor or the second floor, there will be box lunches that are labeled as to their general contents. You can eat them anywhere in this building. You can eat them outside. The Massachusetts Medical Society helped fund a movie that we put together called Getting Better, and we're going to show 2 segments of that movie in this auditorium from 12:45 to 1:15. You're welcome to bring your lunch back into the auditorium if you want to see that. There's no popcorn with your lunch. But we will start our third segment at 1:30 sharp. We have now put up additional signs to help you find the restrooms. We will see you in an hour's time. For the speakers, there's a speaker's lunch upstairs.